Good morning.
Good morning.
Good morning. So, Dr. Saxena, I'm not going to introduce myself. I've been here too long. I will start by thanking our sponsors, Baxter Cardiology and Merck Company, who have kindly agreed to sponsor Grand Rounds this morning. Welcome to the new year, 2026, for what it is. I have the great pleasure of standing up here with my counterpart in crime, my better half, as I'd like to say, Dr. Catherine Bigelow. Dr. Bigelow completed medical school at Mount Sinai. She then proceeded to do her OBGYN residency in the Harvard Medical System at Brigham and Women's and Mass General. They actually have an integrated OB system. Now they have integrated cardiology now, all of a sudden. She then returned to Mount Sinai to complete her fellowship in maternal fetal medicine. She's a board-certified, clinically active maternal fetal medicine specialist with a specific interest in maternal complications of pregnancy. She is quite a prolific researcher and has done so for her entire career, prioritizing preterm birth, labor management, and prevention of pregnancy loss. And then after she finished her fellowship, she joined Minnesota Perinatal Physicians here at Abbott with a particular interest in cardio-obstetrics. And she now currently co-directs the Cardio-OB program with me. So welcome to Dr. Bigelow.
Thank you for the introduction. Thank you. And with that, I would like to introduce our talk. So Dr. Saxena and I will be talking about sort of a practical cardiology guide to cardio-obstetrics, which we're entitling Beyond Normal Pregnancy.
So our hope is that we, again, update a little bit of the epidemiology of mortality in the United States as it pertains to pregnant women. We're going to review some of the ESC CVOB risk stratification, not in great detail. If you guys are interested, the European Society of Cardiology republished their cardio-obstetrics guidelines last August. It's a phenomenal tome. It's great reading. Identify who needs a CVOB referral and who does not and can be managed in general clinic. Recognize high-risk pregnancy and postpartum cardiovascular scenarios. And then review the relationship between pregnancy adverse outcomes, and cardiovascular health. So really, the gist of this is, why does all of this matter? Why are we talking in a cardiology grand rounds about pregnancy? Because if you look at our maternal mortality in the United States, and we have data through 2023, this is 2018 through 2021, and then 2022 and 2023 are over here in the bright blue and green. We can see that year after year, our maternal morbidity and mortality have continued to increase, especially in disparate populations. The United States remains the country that is the top for maternal mortality in the developed world, things we do not want to be proud of. If you look at this very end, the US Black population, so women of color, tend to outstrip every other woman in the world in a developed country for maternal deaths. So why are we here? Well, when we look at the causes of death for these pregnant patients, turns out the majority of them die from things like other cardiovascular conditions, which can be congenital heart disease, ischemic heart disease, valve disease, congestive heart failure, cardiomyopathy, this is our peripartum cardiomyopathy, or other cardiomyopathy, and then hypertensive disorders of pregnancy, things that you all should be doing in your general clinic day in, day out, things that we see. And this is a point that we're going to reiterate over and over again. The majority of these deaths are preventable with good counseling and good management. But wholly a third of pregnancy-related mortality is cardiovascular in nature. It is the #1 cause of death in pregnant women. When do these women die? They tend to die after they deliver. So this is when they're showing up in the emergency room and you're getting consulted for an elevated pro-BNP or for chest discomfort or for an abnormal troponin. The majority of deaths actually happen between days 1 through days 42 postpartum. Again, when they show up with quote unquote asthma, but they really have heart failure, but can be up to 365 days out.
And so because of this, it's really important that pregnancy, particularly first pregnancies, are viewed as a potential stress test to identify women who may have cardiovascular risk. So when we think about the hemodynamics of pregnancy, it's sort of very interesting to see, what does the cardiovascular system do as pregnancy progresses. So the left-sided vertical line is pre-pregnancy. And as you can see, as pregnancy progresses through the first, second, and then third trimester, and then this second vertical line is delivery, which has its own very specific and stressing hemodynamics, you can see that cardiac output, volume, and heart rate are all going to progressively increase in pregnancy with a concurrent decrease in peripheral vascular resistance, and both diastolic and systolic blood pressure should drop. Delivery, like I said, especially with labor contraction, leads to autotransfusion, increasing cardiac output, and then postpartum, those hemodynamic changes persist until about 6 to 12 weeks postpartum. Really, when we're counseling our cardiac patients, we tell them it's really about 12 weeks that their hemodynamics have sort of gone back to that pre-pregnant state. There's a rapid drop in those hemodynamics in the first 2 weeks, but still a lot of those volume changes exist. So cardiac output is going to increase up to about 50% through the course of pregnancy, which can precipitate decompensation for people who are susceptible to cardiac disease or may have underlying disease that is just unknown. And just as a reminder, at term, the uterus is receiving 12% of the cardiac output. So it's a huge sink for that cardiac output and sort of underlies this change in hemodynamics. There are very well-known cardiovascular changes in terms of the imaging and sort of other studies that you guys are very familiar with. In terms of the EKG, the intervals change, the T-wave can become inverted in pregnancy compared to a normal EKG. And in an echocardiogram, there are changes in remodeling a little bit of the biventricular system, left atrial size and volume. But importantly, the things that should never change because of pregnancy alone are the aortic root diameter, biventricular ejection fraction should remain preserved in pregnancy, and pulmonary arterial pressure is also unchanged in pregnancy. So any changes that happen echocardiographically should not be attributed to pregnancy alone. And so because of this, we really think that pregnancy should be approached in a multidisciplinary way. Pregnancy as an etiology of symptoms should be a diagnosis of exclusion. A lot of common pregnancy symptoms are cardiac symptoms, and so therefore are not necessarily just default benign. And as I mentioned previously, we usually unmask underlying disease as opposed to create new disease for pregnant people. Maybe hypertensive disorders of pregnancy, we can argue that's new. And also, cardiology involvement often does end too early, and so it's really why we strive for these multidisciplinary approaches.
And we do think that these patients, especially those that come with pre-existing cardiovascular disease, should be managed with a pregnancy heart team. Just like we have a valve team, we have a high-risk PCI and CV surgery team. We now have, and we have had, a pregnancy heart team. We're actually one of the more sophomoric programs in the country. We've existed full-fledged since about 2019. We have multidisciplinary conference every month that is well attended. We have about 50 or 60 people that show up. You can earn cloud-based CME by going to our meetings every first Tuesday of the month at 7 o'clock. Where we actually discuss all of our patients, discuss delivery planning. We have buy-in from both CV anesthesia as well as OB anesthesiologists. We have buy-in from our electrophysiologists. We utilize our colleagues in pulmonary hypertension, Dr. Cabaway, Dr. Al-Maluli, to help manage our patients. And then we do utilize our valve teams and our invasive teams when we need them. And so again, we believe that we should be taking care of patients from preconception through long-term care. Right now, where our bandwidth is for our program is we see patients preconception to delivery. Unfortunately, just based on availability, we have a really hard time seeing patients postpartum if they haven't been part of our program to begin with. So who should be seen in a cardio-OB clinic? Really, if you have those symptoms, and these are just cardiovascular symptoms, but we think of them as cardiovascular symptoms on steroids. So if you have dyspnea out of proportion to pregnancy, syncope or pre-syncope that isn't explained by just blood pressure, chest pressure, heaviness, tightness that acts in a pattern of ischemia, new or sustained arrhythmias, pulmonary edema, severe hypertension, and then elevated cardiac markers, which we'll talk to about changes in our imaging. These individuals should be considered for referral while pregnant. Preconception, we love to see anybody who's had a prior cardiomyopathy. If you've had peripartum cardiomyopathy, again, the zebra, the rare thing. But if you've had it, we'd like to see you if you're thinking about having another child. Moderate to severe valvular disease, especially stenotic. We're going to talk about valves and heart failure in a few minutes. Aortopathy or a known genetic aortic problem. Pulmonary hypertension, clinically significant arrhythmias, although we do manage that very closely with Dr. Moore. Severe hypertensive disorders of pregnancy and prior pregnancy, especially those that came with pulmonary edema. Congenital heart disease, other than simple things. PFOs do not attribute higher risk. If you've had a repaired ASD or a VSD without any underlying cardiac issues on your echo, that does not increase your risk for further pregnancies, and those necessarily could be managed in a lower risk manner. So who do we not need to see other than the ASD/VSD that's been repaired? These are individuals that could usually be managed by general cardiology or individuals who could be managed by their primary OB. Anybody with isolated sinus tachycardia without structurally abnormal heart, we don't need to see sinus tachycardia. It is usually a problem of other things, not necessarily the heart itself. Benign ectopy with a PVC burden that is much less than 5%, mild, well-controlled hypertension, and then, of course, anybody who has normal cardiac structure and normal cardiac markers. These individuals just need reassurance or management in general clinic with OB. They don't necessarily need to be seen in a high-risk OB setting. So what do? We take a look at the patient. We do CAR-PREG scoring. We do what's called the Modified World Health Organization scoring. So this is from the ESC guidelines from 2025. It helps us ascertain risk. And so when you take a look at both the CAR-PREG score and then the MHU criteria, those individuals who are very low on both, they don't really have an increased risk of having cardiovascular maternal issues during pregnancy. But as you can see, as we get higher in our risk score, so this is like pulmonary hypertension, EFs less than 30, MHU-2 is actually people who've had sustained supraventricular tachycardia. If you've had issues and had prior events, such as admissions for heart failure, admissions for arrhythmia, your risk, your frequency of adverse maternal cardiac events increases. Now, those adverse events could be readmission for heart failure, worsening arrhythmia. Fortunately for us, knock on wood, we have not had maternal mortality, but as you get higher in your risk score, we see that happening.
And so when we're approaching these patients, there's a sort of whole gamut of testing and management strategies that we have. Echocardiography remains our first-line tool for imaging in pregnancy and is well validated, and so is certainly our favorite imaging, especially when someone's presenting with new symptoms or has known cardiac disease. And similarly, the biomarkers are valid in pregnancy and we can follow them longitudinally. I'll talk about them in an upcoming slide. When we think about radiographic studies, ionizing radiation, chest x-ray is safe and really should be first-line imaging for people who have dyspnea, especially if you're looking for other etiologies that may not be cardiac in nature. Chest x-ray is very safe in pregnancy. Depending upon gestational age, you can perform abdominal shielding. And similarly, chest CT and coronary angiography can be performed and are safe in pregnancy, again with abdominal shielding if needed for gestational age benefit. But it's really important to keep in mind that first and foremost, the mother should be evaluated and appropriately have an appropriate diagnosis made. The amount of fetal radiation from a single chest CT is very minimal, and the likelihood of causing either birth defects in early pregnancy or future risk of things like childhood cancers is exceptionally low. MRI we do use a lot for our cardiac patients. The sort of only caveat is in pregnancy we typically avoid gadolinium contrast. There are scenarios in which you can administer gadolinium. It tends to be in the context of neuro-MRI where it will potentially change clinical diagnosis and management. For our cardiac moms, we tend to not need it. But postpartum, breastfeeding does not need to be interrupted after gadolinium. There still are some tables out there that suggest that you do, but multiple societies from the radiology world, both in America, England, Australia, New Zealand, and then the European Society of Radiology, all state that women do not need to pump and dump after gadolinium contrast. So really important for lactating mothers to know they can get their studies and still safely care for their babies. When we think about those biomarkers, this room knows well, and people online, that a pro-BNP of less than 128 is normal. That is the same in pregnancy. And we do start to see elevations in pro-BNP in pregnancy in certain scenarios. So it is typically above 200 in people with preeclampsia because it's a volume-avid state and a state of volume overload. And there is an association between a pro-BNP of more than 300 and peripartum cardiomyopathy or other types of cardiomyopathy. And so that for us is one of our sort of trigger thresholds for which an echocardiogram is then ordered in a pregnant patient. Unless, of course, there's somebody who has known baseline elevation in their pro-BNP. This is a biomarker that we follow longitudinally, particularly for our patients who have a history of cardiomyopathy or moms with congenital heart disease. However, as this group knows, pro-BNP should not be a sole marker of pathology. It can be elevated in a variety of clinical scenarios, and so it's important to know, we have this value, what else is going on with the patient? Troponins, this is another test. We don't routinely measure troponins, but they should absolutely be sent if there's concern for ischemia, PE, index diagnosis of peripartum cardiomyopathy. And a rise and fall in troponin is not something that happens in pregnancy just because of pregnancy itself, and so any rise and fall should be evaluated for ischemia. And with that, we're going to move on to hypertension and heart failure, which is sort of our little continuum.
So we're going to start with pregnancy and hypertension. So hypertension, heart failure, hypertension, we actually think in pregnancy they go hand in hand. You'll see why in a few slides. But I want to start with making sure that you all talk about pregnancy-associated hypertension the way we talk about pregnancy-associated hypertension. So hypertension in pregnancy, so gestational hypertension, preeclampsia, eclampsia are the three adverse pregnancy outcomes that we talk about. They are defined as a rise in blood pressure after 20 weeks of gestation that can last up until 12 weeks postpartum. If it happens before 20 weeks of gestation or lasts past 12 weeks, that's essential hypertension or chronic hypertension. That's what we deal with day in and day out, sometimes in clinic. In pregnancy, it's defined as a blood pressure of greater than 140 and or 90. You don't have to have both on at least 2 occasions. Severe range is a blood pressure greater than 160 and or 110, confirmed as persistent, so 2 readings 15 minutes apart. So if you have chronic hypertension, you usually just get it managed. We'll talk about that in a minute. Gestational hypertension management, it really depends on how severe the blood pressure is. If you happen to have those severe range blood pressures, or you get gestational hypertension and something else, pulmonary edema, about 10% of these patients present with pulmonary edema, what we think of as heart failure, proteinuria, thrombocytopenia, renal insufficiency, changes in liver function tests, or a new onset headache or vision changes, that becomes preeclampsia. Eclampsia is when we add seizure disorder to that. If you have severe ranged blood pressure, that is a medical emergency for pregnancy, and these individuals need to be admitted and managed aggressively. This is when we're thinking about adding things like magnesium drips, et cetera, to manage the risk of having seizures.
And so as Dr. Saxena alluded to, chronic hypertension is certainly something that we see a lot, and you all as cardiologists probably deal with a fair bit in your patient population. And so we'd be a little bit remiss to not talk about the CHAP trial, which was published in 2022 in the New England Journal. So this was a study of 2,400 women who were randomized with mild chronic hypertension to the control group, which was our historical way we managed chronic hypertension in pregnancy, which was just keep them out of the severe range. And the active treatment group was really a tighter blood pressure control, less than 140/90, and providing medication and titrating medication to achieve that goal. And the concern previously had been that if you tightly control people's blood pressure, do you affect placental perfusion? Do you impact fetal growth? And so they specifically looked at fetal growth parameters, and then looking at a major adverse event, which they defined as preeclampsia with severe features, a medically indicated preterm birth. So that's not you broke your water or you started laboring, but you had preeclampsia and had to get delivered. Placental abruption, the placenta shears away from the side of the uterus, or fetal or neonatal death. And so what they found is that when you aggressively and more actively control blood pressure, chronic hypertension, you substantially and significantly decrease risk of that primary composite outcome. And the number needed to treat is 20 pregnant women to achieve that goal, to prevent one major adverse event without any impact on fetal growth or other fetal concern.
So why does preeclampsia matter by itself, let alone the diagnosis of heart failure? Is because we actually see cardiovascular changes in preeclampsia in the heart in and of itself. And again, I'm going to belabor this point, so you're going to hear this over and over again during this talk. About 10% of these women present with pulmonary edema, but we can see increased LV wall thickness. We can see abnormal RV strain. You see a further increase in the left atrial size, and of course, worsening diastolic dysfunction. Individuals who present with preeclampsia, then when you look at their hearts later in life, you can actually see an ongoing issue. This is our friend Malamo in Pennsylvania, who published this in 2021, where she took a look at individuals who'd had preeclampsia and then looked at them 8 to 10 years later. 8 to 10 years later, those individuals who had gestational adverse pregnancy outcomes, hypertensive disorders of pregnancy, and or current hypertension had increasing wall thickness, change in LV remodeling, and worsening diastology. If you happen to have both concomitant hypertension and a prior history of an adverse pregnancy outcome, you were on the worst end of the scale, which is probably why we see individuals showing up with heart failure with preserved ejection fraction about 8 to 10 years after they deliver their index preeclamptic pregnancy.
And so certainly when we see heart failure in pregnancy, we as maternal fetal medicine doctors will of course think about our obstetric etiologies, and then we have a cardio-obstetric program, so people are getting better about the cardiac things. But obstetric things that can cause heart failure include preeclampsia, hypertension. We will just continue to beat this dead horse for a few more minutes. Sepsis can do it. Amniotic fluid embolism is an important but very rare etiology of heart failure in pregnancy. Peripartum cardiomyopathy, which of course we will also allude to or talk more about in a couple of slides. Those intrinsic cardiac etiologies, though, that we've talked about, cardiomyopathies, people with known particularly severe stenotic valvular disease, although certain regurgitant lesions can do it too, folks with congenital heart disease or myocarditis. And then, of course, I think for everybody in the room, we have to remember the non-obstetric, non-cardiac etiologies of heart failure. So those are going to be pulmonary etiologies, hypertension or embolic disease, systemic disorders, infiltrative lung disease, and infiltrative cardiac disease, drug use, and then viral infections can also lead to heart failure in pregnancy. So depending upon sort of the picture you have, there's a different approach to it based on, you can see the table here, or the image. And when we think about the continuum of heart failure in pregnancy, it really truly is a continuum. So we have the HFpEF, the folks who have a left ventricular ejection fraction greater than 50%, all the way down to our HFrEF folks who have an ejection fraction less than 40%. The mid-range ejection fraction is important, that 40 to 45%, because that's where we start to overlap with peripartum cardiomyopathy. And when you look at this continuum and these different categories of ejection fraction, preeclampsia is highly prevalent in all of those groups. And so especially for heart failure with preserved ejection fraction, about 80% of those people are going to have preeclampsia within their clinical picture. We will see that BNP levels would be substantially higher in those who have a reduced ejection fraction in pregnancy, and one-year mortality is also significantly higher in people who have heart failure with reduced ejection fraction in pregnancy of about 16% compared to 0% in both preserved and mid-range ejection fractions.
So here's the big slide, right? The peripartum cardiomyopathy, which is what we're all looking for. By the way, I'm still looking for one case of peripartum cardiomyopathy, please, for our rebirth trial, versus preeclampsia. What is peripartum cardiomyopathy? First of all, it's rare because we've had 2 cases in the last 365 days, neither of which agreed to enroll in rebirth. But it's a non-ischemic cardiomyopathy. By definition, the LVEF has to be less than 45%. So if you're seeing an LVEF of 50, pulmonary edema, elevated BNP, think preeclampsia, which is far more common in our population than peripartum cardiomyopathy. Usually presents in the 3rd trimester, so we see it about 1 to 2 months prior to delivery. So if you're seeing somebody and they're 19 weeks pregnant and their EF is 10, it's probably not this pregnancy's PPCM. Now, it might have been last pregnancy's PPCM that hasn't improved and they just got pregnant again, but usually within the last 1 to 2 months before delivery and then 6 months, although by the Europeans it can be up to 12 months postpartum, and then no other identifiable causes. It's about 1 in 1,000 live births in the United States. Recurrence risk, regardless of whether or not your ejection fraction has improved, is anywhere from 20 to 50%. Of course, the outcomes are stratified by the severity of your left ventricular dysfunction. The worse your EF is, the worse you do. And then the worse your EF is, the risk of death transplant in about a year is about 5 to 10%. Preeclampsia we talked about, but we do see, again, diastolic dysfunction and LV remodeling. You can see EFs down to that 50, 55% range, elevation in BNP. The last 2 patients I thought were going to have preeclampsia actually had pro-BNPs in the 900 range, but their EFs were normal, and it was preeclampsia, not peripartum cardiomyopathy. 2 to 8% of pregnancies worldwide. I just want to shout out for Minnesota, we're about 13 to 15% of pregnancies in the upper Midwest as of the last study we had. Recurrence risk, 20 to 50% with subsequent pregnancies. 16% of maternal deaths are due to hypertensive disorders of pregnancy. But the nice thing is as soon as that fluctuation of fluid is done, about 6 months out, these individuals recover their ejection fraction. So how do we manage heart failure in pregnancy? A lot of our medicines that we're used to using are very, very safe to use in pregnancy. Loop diuretics, people can be diuresed when they're volume overloaded for whatever cause while pregnant. Perfectly safe. Hydralazine, Isordil are standards. We love beta blockers in cardio-OB. Metoprolol succinate has become second nature to my MFF colleagues and the MFM nurses, just like it is to our cardiac team. We do metoprolol succinate or carvedilol very safely. We can do digoxin very safely. We cannot, however, during pregnancy use MRAs, mineral receptor aldosterone antagonists. Spironolactone's a no-no. ACE inhibitors, ARBs, ARNIs, so no Entresto. SGLT2 inhibitors are also not studied, and thus we avoid. Dobutamine is safe to use in the acute setting in the ICU. Nitroglycerin drips or nipride or nitroprusside drips are fine, but you have to monitor fetal heart rate due to the rapid decrease in blood pressure. And of course, there is a risk of fetal cyanide toxicity with nitroprusside. Anticoagulation, depending on the etiology of your heart failure is very, very safe to use. We will not discuss warfarin in this talk because that is an hour and a half long conversation in and of itself. Delivery, and you're going to hear this over and over again from us, we actually prefer, and it is safer to have a spontaneous vaginal delivery if at all possible. Unless you are in cardiogenic shock, need sheaths in, and need to be delivered in the CV OR, spontaneous vaginal delivery, induction of labor, with an epidural that's closely monitored, strict eyes and nose and fluid management actually decreases cardiac work and actually minimizes fluid overload. We'll talk about that in a minute. Postpartum, the game is the same as we do in all of our heart failure patients. It is to optimize and adjust guideline-directed medical therapy. ACE inhibitors are perfectly safe in lactation. The program here has added enalapril, and so OBs, MFM, cardiology, we should be very safe to switch the isodil hydralazine back to enalapril if the plan is not to escalate care. Spironolactone, perfectly safe in lactation and should be started. Again, ARBs, ARNIs, there's no data in lactation, so we avoid it in breastfeeding with the caveat that if your ejection fraction is severely reduced, we have a conversation about risks, benefits of breastfeeding versus GDMT optimization. Beta blockers, of course, safe in lactation. Again, carvedilol or metoprolol succinate. Digoxin, diuretics, safe in lactation. Unfortunately, there is no data for SGLT2 inhibitors. There is coming data for GLP agonists, but most people don't feel comfortable using them just yet, but we're starting to see it more in lactation. Minimize risk of thromboembolic issues, especially if LV thrombus or other risk factors such as AFib is there. And then here's a big plug. If you're seeing an individual, their ejection fraction is very low. As soon as that baby's out, they're ready to get pregnant again. So discuss contraception unless you want to see them back with worsening peripartum cardiomyopathy or cardiogenic shock. If you do not feel comfortable discussing contraception, phone a friend, but discuss contraception and make sure these individuals leave contracepted, because if you are not contracepted, you are planning your next pregnancy. We're going to move on to valve disease. That will also be a theme, contraception.
Yeah.
Valve disease, 1% to 2% of women of reproductive age have some form of valvular disease. A third of heart disease in pregnant people is valve disease. Most common etiology in the United States is actually congenital. Most common etiology in the world is rheumatic. I never thought I would see as much mitral stenosis as I do as a cardiologist in the United States. We probably have the largest collection of rheumatic mitral valve disease because of our pregnancy clinic. General regurgitant lesions, much better tolerated than stenotic. Because of that increased volume and heart rate, lower systemic vascular resistance, we actually see a less amount of regurgitation. Red flag symptoms, it's exactly the same red flag symptoms that we're used to in cardiology clinic. There isn't anything in here other than the headache and vision changes that you all don't deal with day in and day out when you think about cardiac patients. If you hear a loud systolic murmur, pregnancy murmurs are soft, or any diastolic murmur, that is an abnormal finding. If you're full of crackles, that is not a pregnancy finding. And then if you have significant edema, especially that doesn't go away first thing in the morning, that is also not a pregnancy finding. If you've happened to have repaired congenital heart disease, this is something that you should be evaluated hopefully before you get pregnant. And then familial conditions such as bicuspid aortic valve disease should be evaluated, of course, before you get pregnant. Preconception, and we love to see these people preconception. So if you have people with valve disease, congenital disease, familial risk, and they get found to have a bicuspid valve with aortopathy, we're happy to do a preconception visit and talk to them about their risks. They should all have transthoracic echocardiograms. Stress tests, we do like cardiopulmonary stress testing if they have significant valve disease or both. And then invasive hemodynamics, always better to be done pre-conception than during pregnancy, although we do pregnancy. And again, pregnancy is a diagnosis of exclusion.
So when we think about the right side of the heart, that's going to be our tricuspid and pulmonic lesions. These are often congenital heart disease, and so it's really important to let patients know if you follow congenital pregnant or congenital folks that their future pregnancies will always require fetal echocardiogram because of the risk of fetal congenital heart disease in any mom with congenital heart disease. So our team will help coordinate getting them a fetal echo with pediatric cardiology. Rarely do right-sided lesions need an intervention in pregnancy. The one that may would be a pulmonic lesion if there's concomitant right ventricular dysfunction, because those people do have a significant risk of right heart failure, especially if it's a very severe regurgitant lesion, surprisingly. Maybe not surprisingly. Echo in the 3rd trimester is really what we recommend for our people with right-sided valvular disease. And typically we time that around 28 to 32 weeks when they're hitting their peak plasma volume, and then we do delivery planning at that time. And certainly if they have any symptoms of arrhythmia, we recommend rhythm monitors. All of the rhythm monitors that you all typically use are safe and reasonable to use in pregnancy. We use them frequently, and we prefer vaginal delivery for these folks. For left-sided lesions, again, regurgitant lesions tend to be really well tolerated, even if they're quite severe. The exception to that, much like on the right side, will be if there's concurrent left-sided left ventricular failure. So severe symptomatic mitral or aortic regurgitation or left ventricular dysfunction, those people have up to about a 25% risk of heart failure in their pregnancy. So it's important to counsel them about that. Their fetal risk is low overall with regurgitant lesions. The big thing that we worry about, and the people we want to see preconceptually and then follow with our program, are those with stenotic lesions which obstruct the left ventricular outflow tract. And so these people with aortic or mitral stenosis have a lesion with a fixed cardiac output. And those hemodynamic changes of pregnancy really typically aren't well tolerated with that fixed cardiac output. So they have very high risks of arrhythmia, hypoxia, pulmonary edema. And so it's really critical to control some of those hemodynamics. We control heart rate with beta blockers to try to ensure that there's appropriate left ventricular filling by slowing the heart rate and getting flow across a stenotic aortic valve. We use diuretics to ameliorate some of the volume load and pulmonary edema that people can have. And certainly in pregnancy, and we'll talk a little bit about intervention, for severe symptomatic stenosis, balloon valvuloplasty can be pursued. The majority of the valvuloplasties we've done in our program have been in the mitral position, and typically we try to time them in the 2nd trimester, just thinking through sort of cardiac surgery in pregnancy, but it is possible to open up people's valves in pregnancy if needed. When we think about labor and delivery for folks with valve disease, vaginal delivery, again, we're going to be repetitive a little bit. Vaginal delivery is preferred. We absolutely recommend regional anesthesia. We counsel all of our cardio-obstetric patients who would benefit from epidural. We talk to them about it. Regional epidural improves hemodynamics. It blunts some of those major shifts in heart rate and blood pressure that happen during labor, and particularly the 2nd stage, which is expulsion of the fetus, decreases your oxygen consumption in labor. And we do sometimes talk to people about considering an assisted 2nd stage. That means forceps or vacuum-assisted vaginal delivery if we think that there's a reason to shorten and minimize the amount of Valsalva because of those hemodynamics that happen. Why is this? So C-section is major abdominal surgery. I think everyone in this room knows that your folks have to get cardiac clearance for major abdominal surgery. It may be how a third of babies are born in this country, but it is still major abdominal surgery, and so it shouldn't be taken lightly. C-section has higher risks of significant hemorrhage, hemodynamic fluctuations, myocardial oxygen consumption. We also have data to back this up. So a study came out, it's now 6 years old, out of Brigham and Women's where I did my training, and so people in a cardio-obstetric program that we very much admire and respect. They did a study of almost 300 patients with, they looked at planned delivery for their cardio-obstetric patients, and so 76% of their patients had a plan for vaginal delivery. And when they analyzed those women for whom they had recommended vaginal birth, about 76% of those, so 3/4 of them had just a spontaneous vaginal delivery, 10% of them had an operative vaginal delivery, but importantly, only about 2% were for a cardiac indication, so the others had an obstetric indication for their operative vaginal delivery, and they had about a 14% rate of C-section, which is actually better than most places. And importantly, when they looked at their primary cardiac outcomes, for the patients who had vaginal deliveries versus C-sections, those cardiac outcomes were similar. And so it did not seem that C-section was in any way protective for adverse cardiac outcomes. There were no differences in their composite maternal outcomes. And importantly, the vaginal delivery group had lower rates of postpartum hemorrhage, lower rates of blood transfusion, which are other important morbidities in obstetrics for us, and no change in neonatal complications. Now, certainly, people with valvular disease, especially stenotic disease, have really important fluid considerations that we take into account, and we create a very careful and detailed care plan for patients, particularly around delivery. So delivery leads to a rapid fluid shift. With expulsion of the fetus, there is an immediate about 500 cc autotransfusion directly back to the heart from decompression of the inferior vena cava from uterine decompression. So that immediate hit of volume is substantial for people, as you can imagine, that may be quite sensitive to it. And then over the next sort of 1 to 3 days, all of that excessive interstitial fluid that is seen in all pregnancy does pull back into the vascular system and is returned to the heart. So people can have up to about a 2-liter volume back to the heart in those first few days of pregnancy. For mitral stenosis, we know that they're better dry in the context of labor delivery in the immediate peripartum period. They risk flash pulmonary edema, and these are the patients that we usually push IV Lasix with them at that time of delivery to help with that autotransfusion. Aortic stenosis, conversely, they're a little bit better wetter. We'd rather they have some pulmonary edema as opposed to coronary hypoperfusion. We can manage pulmonary edema better than we prefer to manage ischemia on a labor floor, so I'll just say that. But so it's certainly delicate, but overall, the big point is that vaginal delivery is preferred in the majority of these patients.
So do we, or when should we intervene in valves? So pre-pregnancy, we'd prefer it, right? We'd prefer preconception valvular intervention. Individuals who have severe symptomatic aortic stenosis or asymptomatic severe aortic stenosis with LV dysfunction really shouldn't get pregnant until it's fixed. And then if it ends up being surgical, we wait 6 months post-surgery before we okay a pregnancy or consider pregnancy. Severe symptomatic mitral stenosis or mitral stenosis with atrial fibrillation or other high embolic risk factors. Severe pulmonic stenosis, especially if the RV is starting to dilate and fail. Severe symptomatic PR, and then severe AR or MR with LV dysfunction. These are individuals we would love to have valve team see and intervene upon prior to getting pregnant. We think exercise testing, invasive hemodynamics is a really great guide to intervention. What about valve choice? And again, this in and of itself could be an entire topic because of the warfarin use. But mechanical valve versus bioprosthetic valves each have their own issues. Mechanical valve comes with lifelong anticoagulation. So say you have somebody with severe symptomatic aortic stenosis. By nature of our definition, they are the highest risk individual we would see in cardio-OB clinic. They are what we consider an MHU-4 classification. So they have a 40 to 70% upfront maternal morbidity and mortality. By just putting in a mechanical valve, you drop that to an MHU-3, which actually ends up being about 20 to 40% risk. So even though warfarin is a big deal, it's less of a big deal than a severely symptomatic valvular lesion. Bioprosthetic valves, they actually are a little less risky, although interesting data, maybe not as bad, less risky as we think. The problem with bioprosthetic valves, and we'll see data coming out from a lot of my colleagues around the country coming up, where we see that these bioprosthetic valves degenerate much, 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 much more quickly in women and individuals of childbearing age than they do in individuals, even men that we put in at the same age. And so I really think that if you're gonna think about a bioprosthetic valve, please don't be thinking about that valve, be thinking about the second, third, fourth valves that they will be needing down the line in these young individuals. And then again, contraception is key. We are taking care of a patient who's just now been therapeutic with her mechanical valve in the last month and had gotten her valve done in June. Nobody had talked about contraception, showed up pregnant in September. So again, this is a very complicated situation. So please, please, please think about contraception. I just want to point out that we think that bioprosthetic valves are better in these individuals than mechanical valves because warfarin is painful to manage. It is painful to manage. We would both agree with that. But that being said, MACE is similar between mechanical and bioprosthetic valves. There's a 22 times increased risk of having MACE if you have a valve replacement. It increases our length of stay. Yeah, of course, increases our hospitalization costs. But regardless of whether you have a mechanical or a bioprosthetic valve, there's similar maternal outcomes through the postpartum period and similar fetal outcomes in terms of stillbirth and other fetal things. So think about a mechanical valve. I'm a huge fan of the Onyx in the right person. So I think it's really important to have a good conversation with these individuals and not just presume that you know best and make sure it's a continued discussion as well as talking about what comes next. What about during pregnancy? We don't like to do surgery during pregnancy. Cardiopulmonary bypass in pregnancy carries a very, very high risk of morbidity and mortality, and knock on wood, we have not had that opportunity in our program since I've been a part of it since 2018. Huge maternal mortality, huge maternal morbidity, huge fetal loss associated with cardiopulmonary bypass. What about cardiac-based, catheter-based interventions? Much safer. We do percutaneous balloon valvuloplasty for the mitral valve pretty commonly. Again, second trimester Early second trimester is preferred. We've done it very, very safely. I'll shout out to Dr. Bilal Murad at United, who does a lot of our mitral valvuloplasty in our patients that we've taken care of. Requires anesthesia, sometimes a TEE, not always a TEE, and some degree of fluoroscopy, but well shielded. Our moms have done really well. What about transcatheter valve replacement? We actually have a nice few, I'll say few. It's more than a handful now of individuals that we've happened to have valve replacement during pregnancy. Dr. Bigelow and I co-authored a paper that was published in 2024, which actually looked at the management of one of these individuals, and it is safe to do and feasible. There are case reports from all over the country that suggest the same.
And so with that, we'll move on to arrhythmia. Arrhythmia in pregnancy, though we've sort of belabored the point about heart failure, preeclampsia, and valvular disease, the most common complication we're actually going to see in pregnancy is arrhythmia. And that's both for people who have structural heart disease and those that do not. We'll see sustained tachycardia in about 3 in 1,000 pregnancies. And so the figure here really shows you just in normal pregnancy what happens to the heart rate. It does increase longitudinally by about 25% over the course of pregnancy, but the upper limit of normal typically is no higher than about 115. So if a patient comes into your clinic and is just like tacking away at 130, that's not typical, and it definitely warrants some investigation. Certainly for people who have a known arrhythmia, they do benefit from electrophysiologic testing before pregnancy. Number one, because it can help determine whether or not they have a lesion or a type of rhythm that would benefit from definitive treatment. And number two, to adjust their medications to ensure that they're on rhythm medications that have been studied or have more safety in pregnancy, because there are a few rhythm medicines that we don't use in pregnancy. The most common arrhythmia we're going to see, and you all are going to see, and as we mentioned before, can be managed in just general cardiology clinic, is going to be sinus tachycardia, particularly in the 3rd trimester. We also very commonly see isolated supraventricular and ventricular ectopic beats. About 50% of people who complain of palpitations in pregnancy, if you put a Zio on them, that's what they're going to have, is the occasional PVC, PAC. And if it's of a low burden, they don't need treatment, and it does not substantially increase their risk. They remain in that MHU-1 lowest risk cardio-obstetric category. The most common sustained arrhythmia we see by far is supraventricular tachycardia. And the management is the same in pregnancy. So vagal maneuvers remain first line. We teach all of our patients vagal maneuvers, and hopefully if you guys are seeing someone in the ER, for example, you would too. Adenosine remains a first line medication for pharmacologic conversion of SVT, and there's no dose adjustment for pregnancy. And for the patient who's hemodynamically unstable with supraventricular tachycardia, cardioversion is safe and should be used. Cardioversion does not impact placental perfusion or fetal heart rate. It is not something that needs continuous monitoring during it, and so for the unstable patient, she should be cardioverted. I like this illustration. I'm not going to read it to you. Everyone can read and you have access to the slides. But medical management of arrhythmia, first and foremost, is that 12-lead EKG and getting an echo to make sure there's not structural disease to explain the risk of arrhythmia. And then we perform prolonged rhythm monitors with the duration of that depending upon frequency of symptoms. Basic labs, so a TSH, some electrolytes, and hemoglobin, the things that all of us do when we have a patient present to us with concern for arrhythmia. And the reason I like this figure is it really goes through the common arrhythmias that we see and sort of how do you acutely and chronically manage them, which medications can you use. There is a small section on the bottom about cardiac arrest. That is a different scope of conversation, but the main point is that medications are unchanged in maternal cardiac arrest. The main modifications are left lateral uterine displacement and preparation for cesarean section above 20 weeks gestation at 4 minutes of sustained CPR. And then device management. So when we think about definitive treatment of sustained arrhythmia, as Dr. Saxena mentioned, typically we prefer to ablate people, and I alluded to it before. We prefer that before pregnancy. One is the concern about fluoroscopy, but the other is that ablation is more technically challenging to perform and successfully complete in pregnant people because of the changes in the cardiothoracic cavity, the way the heart changes. It's just more challenging to do, and certainly when we work with our EP colleagues, the whole team is very aware and involved with our pregnant patients, but this is tricky to do. ICDs, on the other hand, if a pregnant person has an indication for an ICD, it should absolutely be placed. That's a life-saving device. There are ways to do it to minimize radiation exposure. They can be placed sometimes with echocardiographic guidance. And pregnancy, importantly, when you're counseling patients, does not have an increased risk of ICD complications or an increase in the number of shocks. And so pregnancy itself should not impact the way that ICD functions. The thing we do tell our patients is because of the bodily changes that happen with pregnancy. Sometimes modification or revision of the device needs to happen postpartum because of changes in breast tissue and the way the chest wall is and impedance, but most of the time it's fine.
So we're going to spend a few minutes just talking about what happens later after delivery. So if we think about all those disorders that we see, everything from arrhythmia, heart failure, we didn't talk about coronary artery disease or things like SCAD, aortopathies, pulmonary hypertension, all of those things that pre-exist. Then we have the adverse pregnancy outcomes and probably some underlying cardiometabolic unwellness, which most Americans have cardiometabolic unwellness. We see a worsening of endothelial dysfunction. We can see worsening of ischemia. We can see worsening of inflammation and vasospasm. That actually leads to worsening lifetime cardiovascular disease risk. This is a study from Mike Honenberg and his group at MGH, where they actually looked at UK Biobank data of individuals who had hypertensive disorders of pregnancy and what happened to them long term. Well, of course, they're all at increased risk of having hypertension. So if you're seeing individuals with hypertension and they happen to be able to have been pregnant at one point in time or not, ask them about their adverse pregnancy outcomes. It takes like less than 30 seconds. Chronic hypertension actually accounts for 1/2 to 2/3 of all of this excess risk we're going to talk about. And so treating hypertension may actually keep your patients from being admitted for heart failure or developing aortic stenosis or mitral regurgitation. And as we all know, different hat, different topic, we're not great at managing blood pressure in women.
And so we really think about this 4th trimester, and that's the 12 weeks following delivery. And so I think both of us really like this image because it has a nice marriage of, on the left side, preeclampsia, gestational hypertension, gestational diabetes, and then also just preterm birth, small for gestational age infants. These are adverse pregnancy outcomes that matter. They're not just cardiac, they're not just hypertensive. And then if you look at people's then future cardiovascular risk of things like hypertension and cardiovascular disease, but also stroke, heart failure, diabetes, these are substantially modified by those adverse pregnancy outcomes. And so I will just echo what Dr. Saxena said, which is it doesn't take that much time to say, I see that you've been pregnant 3 times. Did you have any significant complications of pregnancy like preterm birth, preeclampsia, gestational diabetes? Were your babies of a normal weight? And so when we think about the last piece of this, and we've harped on it a few times before, but now it's the slide, on contraception in cardiac patients. And so we talk with all of our delivery planning visits with our cardiac moms, typically in that 3rd trimester. We ask them about their contraceptive plan. But not everybody's going to have the advantage or the opportunity to see us in that pregnancy. They may be somebody who should be contracepted and not get pregnant. So it's really important that all of us take the time to educate ourselves and our patients about contraception. When we think about the image on the left side is really going through the tiers of contraception and efficacy. So tier 1 has a failure rate of less than 1%. These are by far our gold standard best contraceptives. There's, of course, permanent methods of sterilization, both female sterilization with salpingectomy or tubal ligation. The majority of people at this point are getting salpingectomy, which is also a risk-reducing procedure for ovarian cancer. Male sterilization or vasectomy, that of course doesn't then modify your patient's ability to get pregnant, but if they are in a stable monogamous relationship, that is absolutely a good strategy. The reversible tier 1 contraceptives are the things that we counsel people the most about. So that's IUDs, the levonorgestrel IUD, which is a progestin-only IUD. There are a variety of them of different sizes and levonorgestrel doses. The oldest and sort of most commonly known one is Mirena, but there are Liletta, Kylena, there's a bunch. The copper IUD is the Paragard IUD that has a different side effect profile, different people for whom it makes sense to use. And then etonogestrel subdermal implant is also known as Nexplanon. That's a 3-year implant that goes in the upper arm. So those are all exceptional and they have similar rates of failure. Tier 2, these are the things that we start to get a little bit squidgy is probably not a formal word to use, but that's how we feel about it. We feel squidgy about it. So these are things like the combined oral contraceptives pills, Depo, progestin-only pills, which are frankly not very good because they have to be perfectly taken. Patches, rings, diaphragms. I haven't fit someone for a diaphragm since residency. I don't even know if they still make them. And then tier 3, these are ones that we laugh a little bit about, but we roll our eyes. So fertility awareness methods, these do work for some families. You know, this is natural family planning, this is body cycles, these are for people who have some sort of a social or religious opposition to other forms of contraception, and they can be very effective, but they do have a high rate of failure. Barrier methods, that's condoms. Condoms don't work. Please don't send your patient with severe stenosis home with condoms. Spermicide withdrawal, we know these things don't work very well. And certainly when we think about safety, who are the people that should or can get different types of contraception? IUDs are IUDs for all.
IUDs for all.
We should get shirts.
Yeah.
So
There's lots of
really,
shirts.
heart failure,
SCAD.
prosthetic valve, SCAD, these
SCAD.
people, everybody should get IUDs. Contraception that contains estrogen, so that typically is the birth control pills, patches, rings. Those really should be used with caution in people with coronary artery disease like SCAD, who have prior ischemia, who have heart failure, who have cardiomyopathy, and then also in people who have a risk of thrombosis, so
AFib.
mechanical mitral valves, certain arrhythmias like persistent AFib. And we're also cautious in people with hypertension because combined OCPs can elevate that risk. And then once again, barrier methods are not recommended.
So we think education is key. This is education about what to do after you've had an adverse pregnancy outcome. Shout out to Gretchen back there. This is the Broach program from, I have to shout out the foundation at least once in a talk, right? From the Minneapolis Heart Institute Foundation. But I think if you haven't educated yourself about having a conversation about contraception and you see individuals who could become pregnant, especially those individuals who have pulmonary hypertension or valvular disease or prior heart failure, please, please, please just bring up, hey, are you planning on getting pregnant? And if not, how are you avoiding it? And if you don't feel comfortable, send them back to their primaries, send them back to their OBs, but have the conversation. This is a really nice table from this paper that we put together about pregnancy-induced cardiovascular risk. Talks about screening, who to screen, when to screen them, how often to screen them if they've had an adverse pregnancy outcome to help prevent future cardiovascular disease.
And so with that, we will conclude. And so the big things we hope you take away from our talk today are that maternal mortality in the United States remains the highest in the developed world and disproportionately affects women of color in this country, and that cardiovascular disease is the #1 cause of maternal morbidity and mortality in this country. Pregnancy and postpartum symptoms should be considered cardiovascular symptoms until proven otherwise and should always be assessed, whether that be in a general cardiology clinic or in a cardio-obstetric team. And most maternal cardiovascular complications are identifiable early and lead to preventable adverse outcomes. CVOB teams like ours do improve outcomes. There are plenty of papers we didn't go into about why these types of teams do better for moms, and so they should be used appropriately. We certainly have limited resources, but we are here to support you and your patients. And just a reminder that cardiology involvement should not end at delivery, to remember that that year after delivery still remains a very high-risk time for some of our moms. And so with that, we thank you and we welcome questions in the last few minutes. Thanks so much for having us.
Thank you.
Thank you. Any water? Yeah. Yeah, go ahead.
For high-risk patients who are contraceptive averse, how do you help manage? Oh, sorry. Thank you. How do you help manage that risk profile, and how do you help have better outcomes for those patients?
Yeah, so that's tricky. If people didn't hear the beginning, so for people who are contraceptive averse, how do we manage that conversation? How do we approach? One of the things that we often do and suggest is that we have the consult with their partner as well, so that they aren't the only person there, so that they have partner, other support system, or family members who can also be there to hear a little bit about what are you looking at, what is this clinical scenario, what are the risks to you and your potential future child, but also your family, your children that you already have. So that can be one way that we approach it. And then, I mean, part of it too is that we say, like, you're a human, like you're an autonomous person, this isn't prison. You can make a choice, but these are the risks and these are the concerns, and if you have an unintended pregnancy, then these are your next steps. But it's really hard, right? You have to meet people where they are. We certainly can't force contraception on people, but we do try to do it in a very sort of shared decision-making, long conversation. Face-to-face tends to go well with support system present.
And not everybody is then open to contraception, but we've, at least explained and documented the risk. We have several individuals that we've taken care of with rather reduced ejection fractions who are contraceptive averse. So unfortunately, each subsequent pregnancy carries the same risk. It's not like, hey, I successfully survived this pregnancy, the next pregnancy is gonna be less risk. So we counsel them with each subsequent pregnancy, hey, your risk is exactly the same as it was. Any other questions?
Yeah, go ahead.
Thank you. That was an excellent talk. I just had a question on if you could go back to your conclusions. The top one, I think this is probably the most question, or you probably get this question the most, and I have a couple reasons why I would think it's probably the highest in the developed world. But can you speak a little on why you think the maternal mortality in the U.S. remains?
Racism.
Yeah, I'm sure you have a lot of reasons.
It's social determinants of health. We have disproportionate care in the United States. And you can look from the social media to actually the media to actually published data. There is papers upon papers about why we see this. There's been a long history of healthcare suspicion amongst individuals of color is the way I'd word it, for good reason if you go back through our historical rationale for things. But there's a ton of data, and it's just because access is number one. It is hard to access healthcare in the prenatal and peripartum setting, right? You're busy, you have other kids, it's hard to get to. We actually do most of our consultations virtually for that reason. So access is a big one. The hesitancy to even seek care, right? And then just systemic racism being written off.
And we do certainly, so one of the other things we alluded to, and we had to pull the slide just for time, but the study that Dr. Saxena presented in the beginning about if you may remember that it was a bar graph with she had the 3 arrows of the cardiac complications that lead to maternal mortality. And there was a little caveat, a reference there to a study by Main and colleagues, which was published in the American Journal of Obstetrics and Gynecology. It's a few years old at this point, but it looked at cardiac deaths, and the majority of them are preventable deaths. And so that's the other piece of it, is that a lot of symptoms that women present with are not heard or not taken seriously. So that's the other piece of it. Certainly, it's not just women of color. White women too also don't get heard, but they get heard more. And so it's really paying attention to clinical symptoms, those red flag symptoms that we talked about, and doing just basic evaluation, reassuring if needed, but that's how you'll also potentially prevent a lot of these cardiovascular deaths and also deaths from hypertension and embolic disease.
I do want to point out, wearing my other hat, because Gretchen's in the back of the room, it's not just during pregnancy that symptoms go unevaluated. It is women in general when it comes to cardiovascular disease. And so, the interesting thing about that study is it is a decade old this year, and our maternal mortality rates have not declined. Certain states have. I want to shout out California and North Carolina, which actually in the United States have the least maternal mortality because they've done a phenomenal job at managing risk.
Yeah, and certainly states that have maternal morbidity review committees tend to have at least data that we can review and the ability for some introspection and improvement, but a lot of states have gotten rid of their maternal morbidity and mortality review committees in the last few years.
Yeah. So the law passed in 2018. It was voluntary for states. It was great because at least the data was all recorded the same way. We talked about maternal deaths and maternal morbidity in the same state to state to state. Prior to that, it was kind of like a crapshoot of what is maternal mortality. But unfortunately, the pendulum has swung the other way.
Just to follow up on that, do you know the stats on Minnesota? Because I think we do have very good cardiovascular.
So Minnesota does better. From a purely cardiovascular disease with women, I can talk about our maternal. We don't have tight data for maternal morbidity and mortality.
We do have a perinatal quality collaborative in our state, one of the few.
I think the last time I looked at their data, though, we have more morbidity than we do mortality. As a state, despite our rising preeclampsia and gestational hypertension rates, that is Minnesota is a little bit higher in that sense. But I think that is just population because, again, everybody is more cardiometabolically unwell. But in terms of women and heart disease, we're at about 4% of women in Minnesota are living with heart disease, and we have a pretty low maternal female morbidity and mortality from cardiovascular disease, just in general. From the U.S. strokes and heart disease statistics that gets published every year from the preceding years, Minnesota always ranks number 2 for the best stroke and heart disease statistics. So, when I tell people you live in Minnesota, you get good heart care, I can actually say that without being tongue-in-cheek.
Yeah. Any other lingering questions? Otherwise, we, of course, remain available. We have emails and phones and all of it, so happy to help.
Thank you.
Thank you.